We'll now go straight into our next session, which is a continuation of yesterday's intensive imaging workshop. We have with us Dr. Maaz Ali Abbasi, practicing radiologist attached with University College London Hospital, NHS Foundation UK. His presentation for today's session is titled Case-Based Discussions. Please give him a warm welcome.
Right, this is just before lunch, so thank you very much again to the Society for inviting me. It's always a pleasure to come back home to Pakistan. This session is not for the faint-hearted. These are really difficult cases. We'll start off nice and slowly. It's interactive, so this is what you're going to need to join. So we're going to go back to this first case. I'm not sure what the expertise of the audience is, but I'll help you. This is a shoulder MRI. These are 3 sequences. They're all in the same. You don't need to know what the sequence is. It's a fat saturated, so water will appear bright. So here we go. This is the first case. And the first question is, how might this patient present? And you've got 20 seconds. So sudden onset pain and stiffness, red swollen joint, fever and rigors, pain at night and when lifting arm up, asymptomatic, completely incidental finding, and traumatic dislocation. Okay, I think that's time up. So there we go. All right, so we've got a bit of a spread of answers. And the correct answer is pain at night when lifting arm up. Anybody know what this is? Oops. Oh, there you go. Brilliant to see you right at the top. Let's go back. I'm not going to review this case for very long, but essentially this is a subacromial subdeltoid bursitis. Okay, so this is lots of fluid in the bursa. There's a little bit of a tendon tear, so this is supraspinatus, there's a tear, and then there's a large bursa. There's a bit of synovitis up here, and this is all a bursitis. So this will present with pain at night, and you'll get this sort of aching pain when you're lifting your arm up above the horizontal. The other differentials that are given here, they tend to occur with different things. So sudden onset pain and stiffness is more to do with adhesive capsulitis. Red swollen joint would be a septic arthritis. This is your correct answer. And asymptomatic incidental finding, that's unlikely. And traumatic dislocation, also unlikely. By the way, in this quiz, I have included, well, it could have normal cases in it, and there will be some that may have more than one answer. So you can only give one answer, but there might be 2 answers in the list that are correct. So I have tried to be as kind as possible. Okay, so let's get going with the real thing now. Whoops. Okay. Here we go. Anybody know what this is? It's a wrist. Okay, and the crosshair sort of gives away may give away something. This is a wrist. It's an axial wrist, and the question is, what is the most likely presenting complaint for this patient? So numbness and paresthesia, pain, early morning stiffness, triggering, or pale hands and fingers with diminished radial pulse. Okay, so correct answer is numbness and paresthesia in the thumb. So that's nice. So what we were looking at here is, oh, well done, I see he was still caning it, well done, there we go, is the median nerve. So these are all the flexor tendons, these are the carpal bones, these are the extensor tendons, these black things here, and this bright blob here is the median nerve, and it's being compressed in the carpal tunnel. So when you get carpal tunnel syndrome, then you will get numbness in the thumb, the 2 fingers, and half of the ring finger. Okay, it's ramping it up now. Now it's going to get to some more difficult stuff. Okay, so this is, for the people who don't know, if you do know, I'll just tell you anyway. This is a sacroiliac joint. Okay? So have a look at this. Get ready. There we go. So what's the most likely diagnosis? Active sacroiliitis, chronic sacroiliitis, active on chronic sacroiliitis, stress fractures or infection. Okay, time's up. There we go. Fine, what's the correct answer? Brilliant, that's great. Active on chronic sacroiliitis. And how do we know that? Well, that's the correct answer. And how do we know that? Well, Both people were correct in these two, but this was the actual correct answer. And I'll tell you why. We've got an emerging winner. Well done, okay. And that's because there are two sequences here. This is a water-sensitive sequence. That means all the water signal, the fat signal is being nulled out, okay. Therefore, anything that shows up bright will be edema-like signal. So therefore, this is definitely active sacroiliitis. However, if you look at this sequence here, this is a non-fat suppressed sequence. So the fat still looks bright. Look, the fat on the buttocks here, over here it's gray, but here it's bright white, which means this is bright white, which means this is fatty metaplasia, and it's in a periarticular distribution, and the cortical margins are irregular here, so these are erosions. So this is chronic sacroiliitis. So if you said either, you were correct, but the right answer was this is active on chronic sacroiliitis, i.e. you've got chronic sacroiliitis and now you've got active inflammation, okay? So that's what we're looking for. Okay, back to the shoulder again. 3 shoulders, this time no arrows, no nothing. Let's see if you can spot the abnormality. Okay, and we get ready, and here's the quiz now. Next question coming. How might this patient present? Pain when lifting shoulder, red hot shoulder with fever and rigors, recent traumatic dislocation, asymptomatic, and pain and reduction in shoulder movements. Got 8 seconds. Okay, here we go. Correct answer is brilliant. Pain and acute reduction in shoulder movements. That is correct. This is adhesive capsulitis or frozen shoulder. Powering ahead, Fatima Mahmood, brilliant, well done. And what we're seeing here is the inferior capsular ligamentous soft tissues are thickened and there's edema in the inferior capsule. So this is where you see the shoulder capsule, so this is a true capsulitis. The additional thing to look at is the rotator interval where there's synovitis. That's the other thing that you'll see in adhesive capsulitis, and that will present with pain and stiffness. Okay, next case. It's going to get harder and harder. Okay, here we go. I'll give you a few more seconds to look at that. Okay, so next question. What's the most likely history of presenting complaint? Is this an asymptomatic case? Heel pain after jumping from a height? Pain after training for a street marathon? Insidious onset red swollen ankles with fever and rigors? Or clicking painful ankle after a football injury? Okay, and the correct answer is pain after training for a street marathon. Exactly correct. So there's definitely abnormalities in this scan. You can see that, oh brilliant, we've got a new leader. Okay. What you can see is lots of edema. You can see edema in the distal tibia. You can see edema in the calcaneus. Why can't this be someone who's jumped from a height? Well, normally when you jump from a height, you'll get a frank fracture. But this is a very characteristic position of where you get a stress fracture. If it was a frank fracture, the calcaneus opens like an egg. It fractures like an egg. So it doesn't do that here. What we're seeing is edema actually in the non-weight bearing portion. And you're seeing it in the distal tibia as well. So that's very characteristic of a stress injury that you would get if you were training on a street marathon. Okay, it's getting harder now. They are going to get much harder. Okay, I'll just give you a bit of a clue. This is a knee or just below the knee, okay? Okay, you've had enough time. Here we go. We're going to go through this. What is the least likely presenting complaint? So here's a test of your spotting the abnormality and a little bit of anatomy. Let's see how many people get this. I think this is a harder case. Ooh, you all fell for the trap, or lots of you did anyway. Okay. Okay, let me explain to you what's going on at this one. Oh no, oh yeah, that's correct. Sorry. I fell for my own trap. That is correct, sorry. So what were we looking at? So I changed the question from a positive to a negative, that's why I got confused. So this is a tibia, this is a fibula, and this is actually an osteochondroma. And the osteochondroma is compressing here, the tibial nerve. So the one thing that it can't be is compression of the peroneal nerve. And peroneal nerve will be a foot drop. But all the other symptoms, paresthesia, numbness, tingling, difficulty in moving the toes, all completely asymptomatic. that's also, this can present completely asymptomatic. So people like that can have this for years and have actually no symptoms at all, or very difficult to elucidate when you're doing clinical examination. So the correct answer is definitely it can't be a foot drop. Okay, next one. It's going to get harder and harder. These are a little bit harder. I'm not sure how many of these you see in bugs. Oh, maybe you do. Okay, here we go. Oh yeah, you can confer, by the way. I don't mind. Okay, here we go. What is the least likely association for that finding? Okay, let's see. Time's almost over. Okay, here we go. Correct answer is low dose antibiotics, correct. So, bit of a spread of answers on that one. So, what is this? This is bilateral AVN of the hips, okay, of both femoral heads. And all the other answers here are associated with bilateral AVN. The only one is chronic use of antibiotics, which has never been associated with bilateral femoral head AVN. But all the others, chronic interstitial lung disease because you're on long-term steroids, similar long-term steroid, and heroin. Heroin abuse has also been shown to be associated with that, and obviously sickle cell disease, we all know. Okay. Oh, who's the leader actually? Let's see. Oh, Sarah. Okay. Cool. Next. Have a look at this case and give you a few more seconds. This one's a slight easy one. I thought maybe if the confidence was down, this might help you to get confidence up a little bit. Here we go. And let's get on this one now. What is the most likely diagnosis? Okay, let's have a look. Correct answer. Ooh, bit of a spread there. That one's caught more people out than I thought it would. So this is the correct answer is Freiberg's infraction. And so it's not an infarction, but it's an infraction, which is a different thing. And these things don't exist. So that one doesn't exist. So here we go. This is what the correct answer is. So let's see what the leaderboard is looking like. So what we can see here is the second metatarsal head. You can see that the bone is osteonecrotic, and now you've had a osteochondral lesion, a displaced osteochondral lesion. Okay, here we go. Next one. I'll give you 2-3 more seconds to have a look at this. A knee, for those who don't know, but this is a knee. Okay, next question is, what activity might this patient participate in? Doing 20 rakats of Tarawih for the whole of 30 days of Ramadan? Competition level swimming, mixed martial arts, lawn bowls, or long distance running? Okay, and the correct answer is, oh, you know what, I actually thought, I wonder if you can get that with this. I put that in there and I thought, I'm not sure I've never heard of anybody complaining of that. But it's long distance running. But you know, I wondered if you could get this. Right, we've got a proper leaderboard now. This is actually friction, lateral femoral condyle, iliotibial band syndrome, okay? So there's edema in the fat just between the iliotibial band and the femur. So I'm not sure actually. I wonder if you can, if you're doing lots of rukus, I don't know, maybe. Okay, next one. Okay, it's getting harder now. These are definitely, it's going to crank up now. There you go, I'm going to give you a couple more. And I've actually put an arrow there, which I shouldn't have. But it makes it a bit easier for you to see what the problem is. And here we go. Next question, here you go. What's the least likely cause of this problem? Post-septic arthritis, overweight female gender, idiopathic, chronic opioid usage, and post-injection of corticosteroids. Time running out. Anybody know what that is? Just shout out the answer if anyone knows what that is. Or let's see. Chronic opioid usage. That's correct. Well done. So that's the correct answer. Chronic opioid usage. And why is that? Anybody know what this diagnosis is? Well, there's a differential, but when I see this pattern, For me, there's usually only one diagnosis that I go for, and that's rapidly progressive osteoarthritis of the hip, or rapidly aggressive osteoarthritis of the hip. It can be septic arthritis, which is why I put these in, because these actually end up being your differentials. It's rapidly progressive osteoarthritis of the hip is more common in overweight female gender, and it's idiopathic. It's definitely associated with an increased risk with opioid corticosteroid injection, and that appearance can happen after septic arthritis, but I don't like that diagnosis, and unfortunately many patients end up getting treated for chronic antibiotics. They have osteotomies and all sorts of stuff. Usually that's what that is. So the only one that is not associated with that is chronic opioid usage. Right, let's see what the leaderboard's looking like now. Sarah's powering on ahead. Okay, next. Okay, this is hard. This is both lower limbs, if anybody wants to know. Okay, so let's go. What symptom would this patient most likely present with? A few more seconds. Okay. So the correct answer, most people didn't get it, but someone did. It's red or violet face rash. And why is that? Well done, Sarah, again. Well, this is edema in the muscles. It's in the gastrocnemius muscles and in the anterior compartment. So this is dermatomyositis. This is a myositis. And a myositis, therefore, dermatomyositis will present with a rash on the face. So that's what this is. For the people who thought it was a stress fracture, you normally see that on the medial surface of the tibia, which would be up here, not back here in the muscles. Okay, this is hard. A lot of radiologists would miss this. Okay, so everyone's seen this one? It's a shoulder, just in case you didn't see what that was. Okay. Here we go. What symptoms would this patient most likely present with? This is not a bad one to just guess, actually. Okay, and the correct answer is pain and weakness in the shoulder. Excellent. Quite a few good responses there. And that's because this is, anybody know what this is? This is acute brachial neuritis. Okay, so this is Parsonage Turner. And what you see is diffuse muscle edema within the supraspinatus, infraspinatus, and a bit in the teres minor as well. You can see all this edema here, and this is acute brachial neuritis. So these patients present with pain and weakness in the shoulder. Okay, now this is hard. Okay, this can be a career-ending scan for some people like me. Okay, here we go. That's a bit of a clue. Here we go. So what is the next best step? Keep patient nil by mouth, urgent referral to orthopedics, urgent referral to cardiology for heart failure treatment, urgent referral to infectious disease for commencement of high-dose antibiotics, IV heparin, refer to vascular interventional radiology, and urgent CT angiogram. Sorry for the typo in the spelling of 4. Okay. Oh, gosh. Many people are going to miss this one. So the correct answer here is keep nil by mouth and refer to orthopedics. This is necrotizing fasciitis. All of the abnormalities within the fascia. The bone is okay, the muscles are okay. This is necrotizing fasciitis, and this is very avid enhancement of the peripheral tissues, and everything in the middle is not enhancing because it's all necrotic. Okay, so this is a serious problem, and you need urgent fasciectomy for this one. So you keep nil by mouth, refer to orthopedics. Okay, this is a good case. I actually showed this to somebody and they all got it wrong, so you guys could beat a lot of my radiology trainees. Okay, seen this one? Okay. What is the most likely explanation for this finding? You guys might be good at this, actually. I wonder if you see more of it. I don't know. We definitely see lots of this in the UK. Okay, Good. Well done. Good split of answers here. The correct answer is chronic use of bisphosphonates. These are atypical fractures. High velocity injury in a car accident, I guess it's possible, but usually you'd get a dashboard injury or something. This would be an unusual pattern of fractures. Low energy in osteoporotic patient, not really. They tend to be in the femoral neck, etc. Myelomatous, well, you'd have to see a lesion. I couldn't see any lysis there. And this could be iatrogenic. I don't think so. This isn't how they do the osteotomies. They look very irregular, those bone fractures. Hassan Akhlaq, well done, Hassan. But you can see these are very strange fractures, very characteristic. They occur in the junction between the metaphysis and the proximal diaphysis, and you'll have them at both at the same time. And this is due to a chronic bisphosphonate. These are atypical fractures. Okay. Right, here we go. It's the spine, if anyone hadn't noticed. I'm sure you would have. And let's just get on. This one was meant to be a bit of a booster, confidence booster. Let's get some points. Most likely cause. And there we go. Correct answer is, ooh, okay. Oh, there's a few people changing answers there. I didn't know you could do that. That's cheating. Okay, well, all those people that just changed their answer, unlucky. This is IVDU. And I'll tell you why. I'll tell you why this is IVDU. Well, the first thing to notice is you're all right. This is a discitis, so that's very good. So why is this IVDU discitis? Well, the disc is completely destroyed. The end plates have collapsed and fractured. That is very characteristic, and it's a single level, okay? And there's a little bit of a prevertebral mass. That is not, in this case, it's not much of a differentiator because you would see that in TB as well. But in TB, you tend to see it more in the posterior aspect. But this is very characteristic of an IVDU type discitis rather than a TB discitis. Okay, next one, quickly. This is a shoulder. I'm going to whiz through because I think we're running out of time. Okay, here we go. Most likely diagnosis. Hopefully you'll get this. This was meant to be another confidence booster. Okay, correct answer. Good. Lots of people got the correct answer. It's primary osteochondromatosis. So it's definitely osteochondromatosis. Those big round blobs, I'll show you in a minute. But the main thing that's the characteristic thing about it is that they're very large and they're fewer in number. In secondary synovial osteochondromatosis, there tend to be smaller lesions and there's numerous osteochondral lesions. Whereas in this one, they are large and fewer in number. Okay. I've actually got an arrow there and someone's done a measurement, so there we go. Okay. 3 minutes. Oh, okay, fine. I might whiz through to the last few cases then. Let's see if anybody gets those last few. Here we go. Let's see if anybody gets this one. Okay. And what does everyone think this is? Oh, no. That's not the correct answer for most people. The correct answer is, anybody know what these are called? Anybody? This is called a Morel-Lavallée lesion, and it's a sharing type injury, and it's slightly orthopedic-y, but you might see these patients, because these appear weeks, sometimes even months after the injury, so you might see them in a rheumatology clinic, but they may say, oh, well, I did fall off a bike, but I was actually all right afterwards. But this is a sharing type injury. Now, because I am running late, I am going to show you this case just as a contrast. There you go. So this is the next one. And let's just do this one. What's the most likely etiology of that? I want you to see two of them. So here we go. This one is... And then I'm going to whiz towards the end. I've got 4 or 5 really hard cases that are prize-winning cases. So if you can get those, that will be brilliant. Let's see. There you go. Most likely etiology in this case. Tuberculous, correct. And this is a contrast to the one that we just saw, which is much larger mass. The disc is preserved in this case. So in spite of so much abnormality, the disc is actually preserved. And there's a large post-vertebral mass here. Not very much in the way of pre-vertebral. So quite a good contrast to the one that we just saw. Okay, I'm going to whiz through the next few because I want to get to the last few. Let's get that one out of the way. Get that out of the way. I'll get around that one as well. That was an interesting case. Okay, that one I'll get rid of as well. That's adhesive capsulitis of the hip. Okay, here we go. Last three cases. Let's see if anybody can get these ones. These are hard. Okay, here we go. Right, what's the most likely cause for that appearance? Let's see if anybody can get this. This is... I'll be super impressed if you guys get this. Wow. That's actually really impressive. Because the correct answer is Shock's gene deficiency. Anybody know what this thing is? This is a mad lung deformity. And this thing is a Vickers ligament. And mad lung deformity comes because of a deficiency of the Shock's gene. So that's what that is. So whoever got that, Hamza, whoever you are, fantastic. That is a phenomenal answer. Okay, this is the second to last case. Have a look carefully. Okay. So what's the next best step? You have to be really eagle-eyed for this one. Okay, let's see what the answer is. What did everybody get? Ooh, okay, so these are proper differentiators, these ones. Yeah, so many of you spotted that these were gout, but there's no way I'm going to give you gout. I'm going to give you orthopedics. And why is that? So everyone's confused? Well, there's a rim of gas inside that joint. That shouldn't be there. This is a septic arthritis in a gas-forming organism. This patient does have gout, you're absolutely right, but this is all a distraction injury. These are all distractions. He's got chronic gout. That's not the reason I showed this case. It's because there's gas inside the joint. Okay, and I think this is the last one. Ah, this is an amazing case. Let's see if anybody gets this. Okay. The slight clue because of the X that's in the image, which is a bit annoying. Okay, so this will be phenomenal if anybody gets this. What's the most likely diagnosis? Okay, time's up. Oh, this is a real differentiator. Excellent. Okay, so the correct answer is Charcot-Marie-Tooth. This is a really, really, really difficult case. Ah, we have a winner. Hamza, you're a winner. But let's quickly go through this case. This is an onion bulb appearance of the distal sciatic nerve. It's very thickened and expanded. This is called an onion bulb appearance, and you can see the muscles are completely wasted. Okay, so this, I've only seen this. This is the only case I've ever seen like this. This is Charcot-Marie-Tooth. So that was very, very good. And we have a winner, so that's Hamza, who's done very, very well actually, because these are really hard cases. So Hamza, I've got a little prize. Where's the, Hamza, where did you put it? Hamza? Where's Hamza? Who's Hamza? Ah. Cool. Well, that's it. Those are all my cases. I had some others that I wish I'd shown you. I'm going to show you a couple actually before. Can I do this anyway? No quiz. I'll just show you these couple of cases because you might not see these again. So some of you might know I've got an expertise in the ribs and managing of the chest wall, and this is something that's very, very poorly understood. So if there's one case I can show you, It's this one here. In fact, let's just answer this question. Let's see if anybody can get this. Okay, here's the spine. If you haven't seen the answer, try and participate if you can. It's clearly to do with ribs. So here we go. What is the most likely presenting symptom here? You don't need to spend too long on it, but basically, this is a condition that's correct. Progressive loin to groin pain is correct. So this is a patient who has something called iliocostal impingement. So this is a young patient, you can see. They have a very severe scoliosis. This is the iliac crest, and this is the 12th rib. And what you can see is that these right-sided abdominal wall muscles, so that's the obliques and the transverse abdominis, are being displaced because of the crowding in that area. And they will get compression on their 12th nerve. And so these patients will present with a loin to groin pain. And they will have thousands of investigations. And you can see this patient's actually already gone past the stage. They're actually already onto a small bowel study now. But this patient probably would have had ultrasounds, CTKBs, they would have had so many different investigations, and actually the answer was staring right in front of everybody. The reason why they've got pain is because they've got 12th nerve impingement, and that will radiate through to the groin, so it would look very much like a loin to groin pain that you would get with renal colic. But this will be different because it will occur with specific movements. And the patient will describe that. And the clinician will say, I think this is musculoskeletal, but I just can't prove it and I can't think of the mechanism. But this is called iliocostal impingement, and it gets missed. Okay, so this is how this might present. So you might see it in young patients with very severe progressive scoliosis. Okay, or in elderly people with progressive osteoporotic fractures, they will develop a kyphoscoliosis. Again, they are at risk of getting a iliocostal impingement. Okay, cool. That was the only other case that I wanted to see. Okay, cool.
Thank you, Dr. Maaz. That was a very engaging session. I think I speak for us all when we say we really enjoyed it. I'd now like to invite Dr. Ahmed Said, President and Convener of PSR 2025, to please present a token of appreciation to our speaker. Dr. Maaz, if you could kindly join us on stage again.
We now proceed to the Rheumatology and Ophthalmology Board, a collaborative session bringing together specialists from both fields to explore the intersection of autoimmune and ocular diseases. Before we start, I would like to invite our worthy chairs, Professor Zahid Kamal, Dr. Ghulam Mirza, and Dr. Bilal Azim. Our honorable speaker for today is Dr. Sohaib Abbas from Med East Hospital, who will be speaking on autoimmune uveitis, sponsored by CCL Pharma. Please invite him to the stage. Thank you.
So the pleasure of actually having Sohaib speaking in this session is all mine. Sohaib is one of our very enterprising students, graduated from Fatima Memorial when I was there, had interaction with rheumatology, and after doing his ophthalmology, he opted to do fellowship in uveitis. And I was put in connection with Sohaib after many years with a colleague who actually was doing fellowship in rheumatology, जो मेरा भी student था और इनका class fellow था. उसने मुझे कहा एक दिन, आपको पता है वो जो सोहेब था उसने तो rheumatology मैं कर रहा हूँ और वो uveitis की fellowship करके आया है. And that was the day that we have adopted him, and Dr. Zahid Kamal at National, we have a collaboration with him, and like Professor Ghulam Mirza, we have with you for all diseases, but particularly for retina, and we do not trust on anyone other than these three guys who are actually, these two are the gurus who are sitting on this side, and he is the budding uveitis specialist, and I thought, why not you to chair and he to speak, and what a pleasure it is for me today. Thank you. So, and this kind of interdisciplinary things, this Rheum and ophthalmology, I hope should continue in future and would improve our outcomes of our patients who have autoimmune eye diseases. Our diseases can have autoimmune diseases, have eye manifestations, and at times, eye can be the first manifestation, and this is what going to be the theme of today's this combined Rheum and ophthalmology board. Thank you.
Bismillahirrahmanirrahim. My name is Dr. Sohaib Abbas. Professor Abbasi, thank you very much for such kind words. So without further delay, I'm just going to introduce myself a little bit. My name is Dr. Sohaib Abbas. I'm a consultant VR surgeon and student of Professor Ghulam Shabbir, Professor Zahid, Kamal Sahab. Honored to be speaking in front of you. And I have subspecialty in uveitis, which I've done from Moran Eye Institute in the US. So starting off with uveitis, this is Mr. Edwin Smith. He was an artifact dealer back in 1862. He bought this papyrus and he named it the Edwin Smith papyrus. This is it's a really 4,000-year-old document, and it has documentation about patients with uveitis. So humanity has known uveitis for good millennia, I would say. So the first documented uveitis patient was in 1806. The patient had a violent acute ophthalmia in both of her eyes, and she was treated by applying leeches around her eyes. So thank God we have come a long way and we're not treating uveitis this way anymore. Anyhow, coming to the common uveitic entities, we have about 30 to 40 different uveitis entities, and we try to fit in all the patients that we get in any of this category, but many a times we don't get to categorize the patient correctly, and many a times the patient is in the gray zone. So mostly we are etiologically classifying uveitis according to, not because of their cause, but mostly according to their location, their anatomical location that we find in the eye. So first of all, talking about the etiology, a specific etiology is usually not identifiable in many cases, despite a very, very extensive workup. And we term them undifferentiated or idiopathic uveitis. And of all of them, about 70% of the uveitic entities are autoimmune. They're non-infectious. So there's a question, there's this dilemma that we ophthalmologists get, that if a patient comes to us with uveitis and there is no underlying disease in the patient, there is no specific syndromic name that we can give the patient to that specific uveitis, that basically gives us unease. Like human beings, we want to look for reasons. We want to categorize everything into black and white. We don't want anything in the gray zone. But the question is that if we discover an idiopathic systemic disease in a patient with uveitis, will that render the uveitis non-idiopathic? I mean, it's a dilemma. So for example, if there is a child with chronic anterior uveitis, and the child is overall healthy, the child does not have any associated systemic disease, then we would say that the patient has idiopathic uveitis. But suddenly, we have another child who is NA positive and who is diagnosed with juvenile idiopathic arthritis. Suddenly, the ophthalmologist is at rest because probably we have shared our burden with the rheumatologist, but still it does not change the etiology of the disease. It still stays an idiopathic or an undifferentiated disease. So talking about the stepladder algorithm that we adopt in non-infectious autoimmune uveitis, we start with systemic NSAIDs, and we're moving up towards surgery. So we're using biologics somewhere around here. But recently the trends have been changing. So today I'm going to talk about the TNF-alpha inhibitors that we use for autoimmune uveitis. It's a master cytokine. It is synthesized by many cells, and in a uveitic eye, it is found in both the aqueous of the eye and the blood. So it's good to target TNF-alpha if we have a uveitic eye. So quickly talking about the biological blockers that are there. These are recombinant antibodies or the derived proteins. Since they're monoclonal antibodies, so they're going to end with MAB. I don't know if you guys already know this, but I'm sure the rheumatology council knows everything, but I'm talking from the perspective of an ophthalmologist. So if it ends with an UMAB, it's a human antibody. If it ends with ZMAB, it is a chimeric. Murine was used with it. And if it ends with a sept, it's a fusion protein. So talking about the drug development of these biologics, there has been a lot, mostly in oncology and in autoimmune disease in the last 3-4 decades. Talking about adalimumab, Humira was the parent drug, so I've written that here. It's a fully humanized monoclonal TNF-alpha inhibitor antibody. The developer got a Nobel Prize for this. It was first approved for rheumatoid arthritis back in 2000, too, but it received FDA approval for uveitis in 2016. It was a good amount of 14 years before the FDA regulated this for uveitis. So the injection is given, this is the regimen. The therapeutic range for adalimumab in uveitis is GIA, B27 related disease, undifferentiated Behçet's, seronegative, seropositive arthropathies. The adverse effects, I obviously don't need to tell the Rheumatology Council about the adverse effects of TNF-alpha inhibitors, but we have to make sure that all the patients who are going to be on TNF-alpha inhibitors, they've had a good screen of infections, they don't have an underlying malignancy or a family history of malignancy, and the patient should be up to date on their vaccinations. So these are special considerations when we're putting patients of TNF-alpha inhibitors. We have to be very concerned about TB, demyelinating disease, heart failure, malignancy, another immunosuppressive that we might want to add, not specifically for adalimumab. We do that for infliximab. We'd rather have a methotrexate or a mycophenolate combination with that. So vaccinations, we'll try not to give live vaccinations, and aggressive monitoring of all the vital systems. Talking about pregnancy, adalimumab is a Class B product and can be safely used, probably. You guys can actually guide me better in this regard. So the patients that I have been treating with the rheumatologists in our community are patients with Behçet's disease, VKH, GIA, B27 related, vasculitis. This is isolated retinal vasculitis. The patient does not have systemic vasculitis, choroiditis, macular serpiginous and serpiginous both, multifocal choroiditis, sarcoidosis, and a lot of undifferentiated anterior and intermediate uveitis patients. So talking about the biologics, overall on the stepladder algorithm, they fall over here. But the recent studies suggest that they are increasingly becoming first-line treatments for uveitis patients. And since they're neutrophil and macrophage critical uveitis, like Behçet's and Sarwar, they respond really well to TNF-alpha inhibitors. So we would want the patients, if they're diagnosed with Behçet's or sarcoidosis, to have them on TNF-alpha inhibitors from the beginning. And basically what it does is it's going to reduce the need for additional immunomodulation therapies, for steroids. It's going to reduce the adverse effects. It's actually cost effective. If we start, it seems that TNF-alpha inhibitors are expensive, but when it comes to uveitis, you're going to give them injections, you're going to do multiple surgeries for cataract, for glaucoma, for vitreous hemorrhage, for vitritis. So overall, it's pretty cost effective to have the patient be on TNF-alpha inhibitor from the beginning, rather than starting late. There is rapid visual improvement, and there are continued gains for 6 months, and the patient stabilizes by month 12. So what I tell my uveitis patients is that you have to be very patient. It would be 3rd or 6th month before your vision is going to stabilize with TNF-alpha inhibitors. So acute anterior uveitis, it's the most common clinical phenotype of uveitis that we see. The episodes are readily controlled by topical steroids in many cases. So most of them are 30 to 50% positive, especially if we see a non-granulomatous anterior uveitis, which is not bilateral. It's unilateral, but it's alternating. It's never simultaneously bilateral. So if we get a B27 for those patients, it's going to be 80% positive. So all the patients who are B27 positive, the 60 to 70% have associated spondyloarthropathy. And for such patients, if we begin adalimumab therapy from the beginning, so it's going to it's going to eliminate all the recurrences. Most of them, the patient would be in long-term remission, and most importantly, there would be decreased dependence on topical steroids. So topical steroids are going to cause cataract and glaucoma. So their cataract and glaucoma is happening in a uveitic eye because of the inflammation itself and as a response of steroid treatment. So we would not want the patient to be on extended periods of time with topical steroids. A safe dose is probably once or twice a day, topical steroids, that's it. So if we're thinking about going for TNF-alpha inhibitors, so the incidence of these complications is obviously going to reduce. So if we talk about adalimumab in vision-threatening uveitis, that's not just anterior uveitis. It involves the macula, it involves the retina, it involves the optic nerve, multifocal choroiditis. So the patients before adalimumab, in this, it's a very large study, 50% of the patients were on immunosuppressive therapy, immunomodulation therapy, and still their uveitis was not controlled, and 10% of them needed a very high dose, more than 50 mg of steroids. Post adalimumab, 90% of the patients were able to taper their steroids to less than 7.5 mg, which is the immunosuppressive dose. So the patient was on an anti-inflammatory dose of about 5 mg in such patients. So we can say that starting a biological therapy earlier will decrease significantly the need for another immunosuppressive or immunomodulation therapy in a uveitic patient. So this is from the same study. Initially, the patients were on steroids, and in the latest review, most of the patients were off of the steroids, and they were just on TNF-alpha inhibitors. So we are looking at reduction in the number of relapses and the time between each relapse that is happening. Because in uveitis, we have this sawtooth inflammation. There is inflammation, we treat it, it goes back, but there is always some amount of irreversible damage that is taking place in a uveitic eye. So the number of patients losing vision was reduced. The patient has stable and improved vision in long term for majority of the patients. Another important thing is the ocular invasive therapies that we have to use. We have to give patients ocular injections for the inflammation, for vitritis that's taking place, for macular edema that's happening. So if we're using adalimumab for these patients, we're going to look at a decreased number of subtenon triamcinolone injection that needs to be given to the patient, decrease in the number of suprachoroidal injections, and decrease in the number of intravitreal anti-VEGF injections, which we give for macular edema. So they all have, I'm not going to go into the details of the side effects that they have. So whenever you're going into an eye, it's something that scares most of the ophthalmologists, whether you're giving steroids or whether you're giving anti-VEGF for such patients. So obviously, when it comes to TNF-alpha inhibitors, we are very concerned about the side effects as well. So what is the optimum regimen for uveitis patients? So we'd say about 18 to 24 months, but there's little information on what happens if we stop and there are antibodies that have developed. So what happens is if we stop and there is a recurrence of uveitis, it would take about 48 weeks for the uveitis to be under control if we have stopped adalimumab once. So antibody formation might not always result in loss of efficacy. So this is my last slide. I'm sorry I could not show you a lot of pictures because I don't know if that was important or not. Anyhow, this is a horse eye. This is a very mature cataract, and this is the pupil. It's supposed to be round, but it's not round. It's in the shape of a heart. So it's a recurrent uveitis with syneaks and a cataract in a horse. So human beings are not the only species that are getting uveitis. It's horses as well. Thank you. Any questions you might have?
Thank you very much. It was a nice overview and introductory talk about all these things which we can use in uveitis. Just a little question, and obviously in the last few years we have seen that these TNF inhibitors, they are helping a lot and relatively much less toxic than we used to do. Now, what would be your suggestion if a patient comes with anterior uveitis for the first time, one patient who has other joint symptoms, as opposed to another one who has no other symptoms of any kind in the body. So would you try and treat both of them equally, or what would be your criteria of sending somebody, you would do it yourself because you're uveitis specialist, but for ordinary ophthalmologists when would you send somebody to rheumatology?
So basically, I would want to get the labs done, the the imaging and the B27. If the patient is B27 positive, the patient is for sure going to the rheumatologist. And at times it all depends which is above. The eye inflammation is worse or the joint inflammation is worse. Well, what happens is, for many patients who are on JAK inhibitors, let's say, their joint inflammation improves a lot, and that basically controls the uveitis secondarily. But if the patient is overall systemically fine, and I have the patient on topical steroids, if the patient is not controlled on, let's say, loteprednol, it's a milder steroid compared to prednisolone or dexamethasone for once or twice a day, I would want the patient to be on immunosuppression, because Steve Jobs, he's done a lot of work. These are his recommendations back in the US. I've met him, so it's like if your patient needs more than 2 drops a day, the patient should be on immunosuppression. So that would be my cutoff, basically.
Thank you. 2 more quick questions. One, you mentioned
May I,
50%
Professor Khurram,
of
may I
uveitis,
respond to the
Please.
one thing which I would really like to give my input as rheumatologist? Any non-infectious uveitis coming to your practice, how to first reach that this is non-infectious? This is your domain, so your work, there are findings which can point towards more like an infective, and then there is a non-infectious. I know Professor Zahid Kamal at times refers me the patient the same day he has seen, and he refers for rheumatology consult. But generally these are the diseases which are remitting and relapsing, or it may be the just one-time manifestation of that disease which is still simmering somewhere in the body otherwise. And they may not have the second episode and would never ever go to you or any other colleague in town. And no one would ever review the previous records. Everyone is in a hurry. So I would suggest that the recommendations are anyone who is coming with non-infectious uveitis and you have done the screen like IGRA, or VDRL, or all things which you think can be the possible causes, viral, and if it is, even if it has settled, even then, it has to be a patient referred for rheumatology evaluation. Initially, when I started my practice, the senior colleagues, I still remember Professor Dawla and the colleagues who were like art teachers and the teachers, they refer to professor of medicine for evaluation. And I still see that that is happening at some centers. But now we are around 150 to 200 rheumatologists in this country. And it's not that hard to really get hold of a colleague who is sitting just next to you or sitting in the audience. So they should be referred. They should be seen within 2 to 4 weeks ideally, even if the episode has subsided. Because 25 to 40% of these actually would have underlying expa or spondyloarthritis. And at times without any other diseases, we do treat in collaboration just autoimmune eye diseases as well. Because they need immunosuppression. And for that you also need ID to be on board to make sure that they have been screened for all latent infections and there is no active infection ongoing in the eye or elsewhere in the body. And rheumatologists who are the ones who manage these conditions with immunosuppressants. Thank you.
I would like to comment. First of all, it was very illuminating talk, and I have recorded few of the slides. So I would request we should replicate that in the upcoming Lahore Ophthalmo conference in December. And we would also like to invite the rheumatologist in one of the sessions. Fortunately, the infective type of uveitis are rare, isn't it? We see very rarely, but the non-infectious are more common. So my practice is that if the patient gets the first attack, then we order the routine investigations and we treat it ourselves. But if there is recurrence, then we like to involve the rheumatologist so that further screening can be done and managed.
A little addition to that. I think anterior segment and posterior segment. In anterior segment, autoimmune ones or rheumatology associated ones are more common. And even in posterior segment, there are a lot of those, but Infectious are more common in posterior segment. Tuberculosis related, Sargut related, not sarcoid, I mean syphilis related and so many other things. And in anterior segment, what we often miss in the infectious ones are the herpetic ones. So some of them can be herpetic, which we presume that are just autoimmune, but more of those are just autoimmune ones. So he's right over there, but difference in anterior and posterior ones.
There are two questions from the audience by Dr. Madeeha and Dr. Fatma. They want to ask the role of JAK inhibitors in uveitis. Have you used it or any?
Yes, so I've been using tofacitinib with Professor Ahmed, and it's a new venue. So I have a few patients who are on this, and they are all HLA-B27 positive. There are 3 males who are currently on JAK inhibitors, and they're doing pretty fine. So there was another question that whether some JAK inhibitors cause a retinal detachment. So I did some research on that, and I found out that the patients who are being given JAK inhibitors for atopic dermatitis, they are going to get retinal detachments. It's not because of the JAK inhibitors. Atopic disease is generally related with a higher incidence of retinal detachment. So time will tell whether it's causative or associative.
I just have a question, basically a suggestion. In your experience, have you ever read or learned that people are using subtenon or injections of adalimumab to treat uveitis? Can this be used as a research to do?
I don't think so. I don't think
because
so.
if the eye is only involved.
So
it was
not
just my thought that maybe
but
that would be helpful.
methotrexate has been used to some extent, but not for uveitis. It's for proliferative vitreoretinopathy. It's a complication of retinal detachment. So we give intravitreal methotrexate, but with variable success. Professor Ghulam Saab would be the best person to answer that.
Theoretically speaking,
no, your theory is absolutely right, and I haven't heard of it being used like that, but certainly a place, and we'll look it up and we'll try and see if anybody has tried, or we can start discussing this, and maybe it'll make things easier. But another question again. We are presuming mostly here that these help in, and there is some underlying process going on in the body as well. So giving a subtenon would not address that at all. So,
we were just discussing the cost of these agents, but the point is that most of these patients who get uveitis, they are at the peak of their career, most productive part of their life, 20 to 50 years. And when they get recurrent problem, I imagine that, they lose sometimes, they have to be off their work for 1 week. So if you consider that cost, yes, I think it works out.
And the quality of life.
And considering the quality of life, moreover, the overall complication. Especially I would like to mention one thing which may be sometime overlooked, is the juvenile chronic arthritis. Because the children, they don't complain much and they have white eyes. But slowly they get recurrent attacks and they get
they
blind.
They present with complications, yes, usually irreversible. So yes.
One quick
question.
As opposed to adalimumab, this ZMAB group, how often do you have to revert to that? And because it's murine and everything.
So that's basically, I would say, something which the rheumatologist would. So the question is, when would we revert from adalimumab to infliximab? That's what he's saying. In the uveitis.
Both are monoclonal antibodies. Both are anti-TNF inhibitors. You can use any one of them. The sub-Q injection adalimumab has a better compliance as compared to IV, but at times, yes, IV infliximab at times is funded by insurance because it's an inpatient treatment at times, and it is a better option for those. Risk of reactivation of a latent TB is little more higher with infliximab, and later on formation of autoantibodies against infliximab is also high. So generally we prefer the adalimumab in our patients. I published in 2023 with my fellow colleague Rahil Jonas a study on 52 patients with autoimmune uveitis in our setting, which we were co-managing with Dr. Sohaib, most of them. So we used in around 60% of them, they were actually on adalimumab, and they were on for long term. And the second commonest disease-modifying non-biologic was mycophenolate mofetil, and then was methotrexate. We hardly use azathioprine. Yes, we do combine cyclosporin at times with methotrexate. And you have very rightly said, the disease which is more posterior, which doesn't actually is manifested in the form of a red eye and just blurring of vision and associated diseases are again of our spectrum, from Behçet's to sarcoidosis to even birdshot retinopathy, what to talk of. So these are all things which actually require mutual collaborations between the two disciplines. And I'm very glad and I'm really happy that this has started at least happening in this city. And I hope that this would happen nationwide and we would be having better outcomes of our uveitis patients. And I think I would request now the worthy chairs to conclude the session because we have our next session starting in just a few minutes.
So thank you very much.
So we are,
Sir, I think
we are
there was this
thankful to
question you
everyone,
were-
thankful to Dr. Ahmed Saeed and Sohaib for your time. And it was obviously always useful to us in ophthalmology, but to everyone else. So thank you very much.
Thank you.
And hopefully we will discuss this more in the upcoming December conference of ophthalmology.
Inshallah.
Thank you to our speaker and the audience for a thoughtful exchange. I'd now like to invite our worthy chairs, Professor Zahid Kamal, Dr. Ghulam Mirza, Dr. Bilal Azim, along with Professor Dr. Ahmed Saeed, President and Convener of PSR 2025, to please present a token of appreciation to our speaker, Dr. Sohaib Abbas. Dr. Sohaib, please join us on stage. Thank you. I'd now like to request Dr. Ahmed Saeed to please present a token of appreciation to our chairs. Professor Zahid Kamal. Dr. Ghulam Mirza. And Dr. Bilal Azim. Thank you so much, and with that, we conclude this session.